started. My name is Ricky Skiffington, and I was the team lead for the Narcotic Administration Mistake Proofing project that we did on level 5. In front of you, you can see our standard work combination sheet, and all of our team members, there's 4 out of the 5 that are here today, and we'll all be speaking twice to a takt time of 20 minutes. So you can see who our team is. On your far left is myself, Ricky Skiffington, then Darlene Batty, Donna Cook, and Brett Enns is a nice tall man on the end towering over us. And you can also see there's a little pie plate that I'm holding up, and there's a picture of Steve Old in his nice suit and tie on his pie plate because he's been away for the last little bit. So.
Good morning, I'm Darlene Batty. So this is our mistake proofing project form. Thanks, Brett. So the current situation on level 5 is that there are 4 medication carts, each of which is either being used by an LPN or a registered nurse. And during our time on the Gemba, collecting our timings and speaking to the staff, we noticed a lot of areas, reasons why medication errors are possibly occurring. Medication carts are in a very busy location. There are huge numbers of interruptions, some being telephones, doctors coming for rounds, the telephone, as I mentioned, patients asking for information, families asking for information. So that was a huge factor in the possibility of medication errors being happening. The second one was the MAR sometimes not on the chart or on the cart for comparison because the chart is, or the MAR is with the doctors for rounds. And the other area was confusion in medications of similar names. So we had some ideas for improvement, self-checks throughout the entire process, and that's currently being done at the end of the line. We identified that we need to create a way to better identify medications of similar names. And another area that was brought to our attention was the CAD pumps and the usage of them. Sometimes the time between the pharmacy getting the orders and the CAD pumps arriving on the unit was a huge difference. But we felt that that was an issue that should be dealt with separately. So we put that on our newspaper. So our theme boundaries were to reduce the potential client harm by eliminating narcotic medication errors that occur on level 5. The target was from the time the narcotic is dispensed in pharmacy to the time the patient actually receives the narcotic on level 5. But we felt that was much too broad, so we narrowed it down to looking at just the process of dispensing a scheduled narcotic on level 5.
Thank you. My name is Brett Enns, and I have bifocals and it's dark in here. And all of a sudden the wording looks much smaller than it normally does. So anyway, here we go. The next slide on in our presentation is regarding the present state value stream map, and as you can see, we looked at 2 different pieces of that, the flow of the narcotic as well as the flow of the information. Throughout that process, what the biggest takeaway was is this is a very complex process. Delivering medications in general is a complex piece, but when you add a narcotic in the mix, it becomes even more complex. If you look at the amount of time that it takes to go through from actually finding the medication, finding the right medication on the MAR, and then following all the steps through the process, we looked at anywhere from about 5 minutes to 9 minutes in actual delivery. As you can see in the next 2 slides, we've seen some different time observations and noticed that there was a number of issues there that caused this to be quite confusing on the floor. A number of the starbursts that we had back on this page, it showed that interruptions were a huge piece of the equation for the nurses there. We found that the location of the narcotics within the cabinet was an issue, that nurses were being asked to multitask rather than just being a deliverer of medication. They became multitaskers in terms of taking vital signs, helping with care, all of those sorts of pieces, all added to the issues surrounding the delivery.
Good morning, my name is Donna Cook and I'm part of PAPHR KPO. So what you're seeing now is our Virginia Mason mistake proofing assignment sheet. And pre-Kaizen, Brett and Darlene have already mentioned our theme and also the 3 contributing factors. I'll just reiterate though that interruptions, multitasking, and med confusion, the look-alike, sound-alike, were the 3 contributing factors. So the level of inspection to start at was a level 2. We did go and do some actual observations, and out of 11 observations, we did find 2 errors. So the defect rate became an 18% defect. Post-Kaizen, the level of inspection reached a 3. We did some more observations, so we went and did 9 more and didn't see any defects occur at all post-Kaizen. So we will get into what we did to attain this level right up next.
Okay, so it's Ricky here again. So prior to going down to Seattle, we did a little bit of data collection that we did just get a background idea of what was going on. So we did look at the incident reports for 2012. However, we looked at them and kind of analyzed them, but when talking with Virginia Mason, they had mentioned that for our actual defect rates, that not to include those just because you couldn't then go back and do any investigation. It actually was really hard to figure out what exactly went on with the incident reports, but we did use it to give you an idea of what was going on. So the first one is a little hard to see, but it was narcotic errors by month for 2012, and there was an increased rate over April and May. And after talking with the staff, part of that could very well be that there are a lot of nursing students on the ward at that time. Not saying the nursing students are doing the errors, but a little bit more confusion, more interruptions, and more people at the med cart than normal. Narcotic errors by time of occurrence. There was a higher rate at 0800 hours, 1400 hours, and 2000 hours, which makes sense when you look at the fact that that's when narcotics are scheduled, so they're given more often at those times. By type of error, there were a number of different reasons, but the main key one was the wrong dose was given. And then for our actual narcotics that we had observed, so there was 11 that we had observed, 2 errors that happened, and that were defects that we did see. One was a defect and one was a near miss that we had seen. So this was just an example pre-Kaizen of some questionnaires that we did with staff just to get some ideas of what was going on, what their thoughts were about the errors that were occurring, did they think they were happening, and why. And then just our target progress report. So as Donna mentioned, we were a level 2 of inspection and our target was a 4. We were at an 18% defect rate and our goal was to be 0. There was no standard work for restocking the med cart, narcotic administration, or a narcotic education package, and we were hoping to have this in place. There was inventory, a baseline of 26. We would like a target of 0. Lead time was 8 minutes, 9 seconds, and we were hoping for 4 minutes. And 5S, we were a 1, and we were hoping for a 3.
Okay, so following our learnings at Virginia Mason, we went back to the ward and had 4 short meetings with the staff there on level 5. And from that we gathered information on why they thought the errors were happening and what they felt we could do to stop those errors from happening. So you'll see in this, just some of the ideas were written down. We discussed all of the data that we had collected with them, and from there then we went into some ideas of how to fix things. So this idea sheet isn't showing up very well here in PA, but really it's talking about the interruptions. One of the ideas we had was to sort of create a zone around the med cart that was a barrier so people wouldn't come and just interrupt the nurse who was passing meds. And this is still a work in progress, and you will see some pictures of our first PDSA, which already Tanis is laughing about. It's really cute. But the long-term goal is to actually have Lexan or Lexon, I'm not sure how you pronounce it, it's a type of plexiglass that would go around the medication cart and would create that barrier, which would really decrease interruptions for nurses passing meds. So that is on a work order, and our colleague Steve Old was instrumental in helping us with that. So we first went to collect some baseline data around interruptions, and here you would see that there were a total of 75 interruptions during a 1.5 hour med pass. So really this was the 8 o'clock in the morning med pass. The nurse would start these medications at 7:30, we found, and generally finish right around 9 o'clock. 67 of those interruptions were by someone. So that was somebody coming up and interrupting the nurse. The other 8 were that the nurse was needing to go look for supplies or needing to interrupt somebody else for interruptions. So this was our first go at do not disturb and a barrier. We called it the tiki cart. It definitely created a lot of conversation. Doctors were quite intrigued with it, thought maybe a happy hour was occurring. But in all honesty, it did decrease the interruptions somewhat. We asked the nurses what they thought about the tiki cart, and just a little stick tally to show that 37% of them did feel that that was decreasing interruptions. We went back and did another interruption study and found that we still had a high number of interruptions. There were 76, but at the time of this study, the nurse who was passing meds was orientating a new nurse. So the number of interrupted by someone did decrease to 24 from 67, but there were still 52 interrupt someone, and that was because the new nurse was needing to ask a lot of questions, and we were diligent in collecting all of those interruptions, so we did see that that was still happening. But the main important point was that the interruptions by someone did decrease. We next created a letter to go out to all physicians asking for their input on how to decrease these interruptions, because we have had some conversations and got some good ideas from doctors already about how to decrease interruptions. So this letter went out, and our process owner would be gathering information from them as it comes in. The tiki cart fell apart, and this was our next kick at the can before we get the Lexon up on the cart. So there are big signs on all 4 carts on level 5 that say, "Stop, please do not interrupt the medication nurse." We went back and did another interruption study, and you can see already how few lines there are on this graph. There were only 5 interruptions after all of our PDSAs. The number of interrupted by someone was 3, and the number of interrupt someone was 0. Sorry, I wanted to mention that in these interruptions, the patients were 2 interruptions. The nurse who was passing meds on this day actually went and answered 2 call bells, which we hadn't observed prior to this, although we knew it occurred. But the nurse on this day felt that she did have time to answer the bells. Just of interest too, this wasn't something that we documented with our stopwatch, but we did time, what time we got there and what time we left. On this interruption study, the nurse started passing her meds at 20 to 8 and finished at 8:45. So that also decreased by 25 minutes. So that was impressive as well.
So with interruptions attacked, we moved on to the next idea, and that was around kind of the clutter and the unnecessary items on the medication cart. And the second thing that we looked at was kind of the narcotic confusion. A number of narcotics are sitting in the narcotic drawer while we didn't have the opportunity to change out that cart or that particular drawer, that there are so many different dosages of the same medications, and they're all packaged the same, and so there was a lot of confusion around that. So our approach was to do a 5S on the medication carts, and what we looked at, we worked with one of the nursing staff on the floor. Her name was Brianne. And from there, we looked at the clutter, we looked at the unorganized piece. We also, although we didn't touch the narcotics, we did look at that and made some suggestions and talked with pharmacy about how we might work on that. And then the fourth thing was that we created standard work for replenishing the cart. When we looked at our targets, we wanted to achieve 3. We ended up almost getting there at 2.6. When we did look at the carts themselves, we actually removed 26 unneeded items. Anything from a bag that was from grocery bag to, but one of those hard plastic grocery bags, to a Foley catheter. So there was lots of things on the med cart, just in case you might need them. So from that, we removed a number of those items. We thought the other thing that we could do was, especially when we observed the new staff person orientating, she had to open up every drawer almost every time she looked for a medication just to find things. So what we did was we went ahead and we started to pull out some of the clutter that you can see here in the slide. Pre and post is on each of those sides. What you can see in this slide is the number. We also added labeling to the cart to make it more visual. Again, just kind of reorganizing some things. Save some room there, and here's another slide with the labeling, and folks have really appreciated that. Also, what we did was created standard work, and as you can see here, this information just shows that from at the beginning and the end of the shift, it's a document that helps them identify what it is they need to look for in replenishing.
So we've already talked about lots of different things we are trying to implement to help reduce the narcotic errors on level 5. So this idea summary sheet again just shows the lack of information regarding narcotics, where to find the process for how to administer, comparison of which name does what. Oops. Sorry about that. So we've actually had a lot of assistance developing a safe narcotic administration practices. So this was done with the help of pharmacy, quality improvement, and the nurse educators. So here's a slide again, just showing no standard work. Part of the thing that we observed when we were on the Gamba was that there was no standard process for giving meds. Some people unlocked the med cart or the narcotic drawer first. Some people checked the MAR. The same nurse didn't even follow the same process in the same day giving narcotics. So we really recognize the need for developing standard work. So here is a standard work sheet that indicates the task sequence, the definition of this task, and also the task cycle time. So every staff member will be educated on the process to follow, so they're giving the medications the same way every time. This is a idea summary sheet. Again, one of the assignments is possibly serving on a code blue team. So if the nurse is giving medications and gets called to a code blue, she comes back and she's really unsure where she left off, and then the process of having someone else assigned to the code blue team. This is a multiple skills training checklist. We've added the processes we've implementing, the process for restocking the med cart, the education package, and then standard work. So as the employees are educated on the process, they get a nice full little circle.
Okay, so this you can see is our narcotic doses that we observed. So there were no defects that were observed over the month of September. A couple time observation forms. Our post-Kaizen value stream map, you can see now that we went from 8 minutes and 9 seconds to 3 minutes and 30 seconds. And value added is now 7% and non-value added is 23%. Our targets for the most part, percent change, we were at 100%. For most things, 33% for our level of inspection and 92% for inventory. Newspaper, there are a few items. The multi-skill training needs to take place for the newspaper, and then the physicians are sending in their info to Tanis, and she's going to compile that and implement it. Workshop summary, level 5 staff was amazing. They were helpful from start to finish. The data was very revealing. Standard work's very useful in a complex system. 5S was very revealing. Small changes can make a big difference, and you can count on your team members. We had 3 out of 5 team members have surgery during the project, and everyone pitched in to make things work when we were all unavailable. And thank you.